This program is brought to you by Emory University.
Good morning, everyone. Thank you for joining. It is my pleasure to introduce one of our own, Dr. Jonathan Kim, who is an associate professor of medicine and chief of sports cardiology within the Division of Cardiology and Orthopedics at Emory. And he also has an adjunct faculty position at Georgia Tech. Dr. Kim received his Bachelor of Science at Emory and was a Fulbright scholar. He went to Vanderbilt for medical school, and then did his Med-Peds residency at Mass General, and then returned for cardiology fellowship here at Emory, and he was a chief fellow here. In addition to his clinical role, he has an NIH-funded K grant where he's looking at doing some very interesting research related to sports medicine. He's also the team cardiologist for the Falcons, Braves, Hawks, Dream, sports medicine at Emory and Georgia Tech. Is also on the NBA Cardiac Advisory Committee, NFL Cardiovascular Task Force, on the ACC for Sports and Exercise Council. He consults for Major League Baseball and is also the co-medical director of the AJC Peachtree Road Race. So we're very excited to have you speak this morning, Jonathan, and hear what you have to say about this topic that's been in the news a lot lately for sure. And it's COVID-19 and athlete's heart. What are the complications?
Well, thank you very much, Pooja, for the introduction. And it is great to be able to present again at Emory Cardiovascular Grand Rounds. It's been a few years since I presented in this forum. And I thought this would be an excellent opportunity, as Pooja just mentioned, to discuss a really important topic that's been out in the mainstream media news, and certainly in the field of cardiology and sports cardiology. And that's the discussion of the effects of COVID-19 on the athletic heart. What are the real complications? And of course, a discussion on return to competitive or intense exercise training. And it's a nice 2-week window here. Last week, we heard an excellent summary from Dr. Cutchins on COVID-19 and autonomic dysfunction. And this week, we'll take a deeper dive into the athletic heart. You already heard all my disclosures. So I already have I have several important primary objectives for everyone to take away by the end of this talk. First, we're going to go through the data, what the evidence has shown over the last year, and gain an appreciation of what we know and still don't know about the effects of COVID-19 infection on the athletic heart. We're going to go through the dynamic evolution of consensus return to play recommendations. It's really been an accelerated year for this, certainly as it relates to typical, when you have the need for recommendations and it takes time to garner evidence. This was really a fast forward on this over the last year, just given the real need from the sports medicine community to have guidance for these questions. Of course, that'll include a discussion of the controversy of screening, and note I say in quotation screening, cardiac MRI after COVID-19 infection. And I'll conclude with an update on the approach to return to exercise training after COVID-19. Some of this is still more my opinion versus what's out there, but I think it'll help provide guidance for all of us who not only may deal with those who have patients who are on the higher spectrum of exercise training, but certainly for those who just have patients who ask, hey, can I start exercising? I had COVID-19. Perhaps they just want to get to your mandated 150 minutes of AHA guided exercise and not an athlete, and hopefully we'll provide a little bit of a window into how to guide those patients who have questions. So it seems silly to start off with an introductory side on COVID-19. Obviously, this has been an unprecedented year, but we have to start somewhere. So just to, again, go through some initial basics. We all know it's attributed to infection with SARS-CoV-2. The numbers change every month, but just in the US, present more than 44 million cases. Of course, that's an underrepresentation of what's truly the actual number. But as it relates to mortality, more than 700,000 deaths. We're all aware of the wide range of cardiovascular sequelae related to COVID-19 infection. And again, this is also very dynamic. In the beginning, we had concerns about exactly what was going on with the heart. And at present, there's a newfound appreciation, as we heard last week, about FACC, post-acute sequelae of COVID-19, of course, colloquially referred to as long-haul COVID-19. And this is certainly an issue for us in cardiology as well that we are dealing with now and will continue to have to deal with in the patients that we see. So in understanding how this has changed over the last year and to gain this appreciation, I think it is important to go through this in temporal fashion because it has been a very fast year from when this all started, and certainly the tone has changed dramatically since March of last year. So speaking in the tunnel vision lens of sports, I would submit that March 11th was the day the sports world stopped. Now, clearly the cessation of sports in the beginning of the pandemic was the least important aspect of all the things that we were worried about back in the spring of 2020. But I would also submit that when sports shut down, it certainly became quite real, the national lockdown that soon commenced for all of us, certainly us in the sports world. And on March 11th, this was a contest between the Utah Jazz at the Oklahoma City Thunder, and actually in quite dramatic fashion, the game was halted right before tip-off when it was disclosed that a member of the Jazz, a player named Rudy Gobert, tested positive for COVID-19. Interestingly, this was also the night that we learned Tom Hanks tested positive. So there was a lot of news and a lot of fear, I think, that was spread just in that one day. And in subsequent and rapid fashion over the next 24 to 48 hours, not only was the NBA season halted indefinitely, Major League Baseball, the season initiation was postponed. Same with MLS. The March Madness and the Final Four was canceled. And of note, for those who didn't know, that was actually the Final Four supposed to take place here in Atlanta at Mercedes-Benz Stadium. The NHL season was halted indefinitely. And of course, the Masters tournament was also indefinitely postponed. So we all recognize that there is tropism for the cardiovascular system upon infection with COVID-19. These are all facts that we're all aware of. The virus binding to the ACE2 receptor, which is present on the respiratory epithelia as well as the vascular endothelium. And we all clearly understand that those who are older, those patients with underlying cardiovascular comorbidities such as hypertension, coronary disease, and diabetes are all at risk for adverse sequelae, cardiovascular sequelae after COVID-19 infection. Manifest as acute cardiac injury, myocarditis, precipitation of acute coronary syndromes, provocation of malignant ventricular arrhythmias, as well as thromboembolic phenomena. And these are just a summary of some of the initial large observational case series that were published in the beginning of the pandemic, demonstrating again that those patients who were sicker and admitted in ICU, who were older with comorbidities, clearly had a much higher prevalence of acute cardiac injury, as well as a wide range of other adverse cardiovascular sequelae, much higher than what you would expect or what's been known about other common respiratory viral pathogens, even those who are much more sick and admitted in the hospital. And this raised a lot of concerns in the sports medicine and sports cardiology community about exactly what could be going on in those with milder forms of illness. We all recognize that clearly at some point athletes were going to be coming back for competition, but even those high-end athletes training at home, exactly what could be going on from a prevalence of cardiac injury standpoint and those who are not as ill requiring hospitalization. That initially drove a lot of our concerns and clearly recognize the need for guidance within the community. So of course, the large concern as it relates to acute cardiac injury is the concern for the presence of underlying myocarditis. And I put myocarditis with a question mark because we've also learned over the last year, based on autopsy-based data, that you don't see the classic lymphocytic infiltration with classic viral myocarditis, much more the presence of monocyte and macrophage infiltrates. And really the underlying mechanisms for cardiac injury remains somewhat uncertain. It does appear there's a bigger autoimmune or an immune component to this. But the bottom line is, with acute cardiac injury, concern for myocardial inflammation, myocarditis in athletes was a large concern, given the fact that we're all aware that myocarditis is a common cause of sudden cardiac death in athletes. So the pie chart shown below is a classic pie chart published and shown by Barry Marin back in 2007. Now, the etiologies for cardiac arrest, death in athletes certainly has changed. The most common cause of sudden cardiac death in athletes is actually sudden unexplained death, the autopsy negative cases of sudden cardiac death. But hypertrophic cardiomyopathy still represents the most common structural cause of sudden death in athletes. And no matter what, your top 5 is always going to include myocarditis. So moving into the spring, later spring of 2020, we were getting a lot of reach out from sports medicine physicians we work with, athletic trainers, again, clearly recognizing that this was going to become an issue. And what are we going to do when athletes come back after COVID-19 infection as it relates to return to play? So this was the first document that we wrote. This was sponsored by the ACC Sports and Exercise Cardiology Council and Section. I co-wrote this document with my colleague Dermot Phelan, who's at Atrium Health in Charlotte, North Carolina, along with other authors. And again, this was to provide that initial guidance, recognizing that we had not a shred of evidence, and this was all based on extrapolation of data among sicker patients who were clearly not an apples to apples comparison to competitive athletes. Initially, the statement was also not intended to guide public health policy. This wasn't meant to be a commentary on whether or not sports should proceed. It was all about the return to play, the return to that algorithm and the protocol, the guidance for those returning to training after COVID-19 infection. And there were many populations that we weren't addressing: younger athletes, masters athletes. Obviously, this was also not meant to be an algorithm for a routine return to exercise for a patient in the general population. And of course, what was interesting and what's relevant to acknowledge at present is we had a lot of limitations in what we were saying at the time. We didn't know what the prevalence of asymptomatic COVID-19 infection was in the general population, and the prevalence of cardiac injury in asymptomatic or mildly ill patients with COVID-19 also unknown. And this was clearly acknowledged in the document. This was published in JAMA Cardiology, and we're not going to go through each and every one of these boxes. Obviously, this is really an outdated document. But what was emphasized was a couple things. Number one, if you were asymptomatic, we still at the time didn't feel that you needed to have any sort of testing. We should note that professional leagues, schools throughout the NCAA Power 5, ACC, Big Ten, SEC, for example, were testing all athletes. But what we did say was, even if you had mild COVID-19 symptoms or mild URI symptoms, as an example, there should be testing before allowing return to play. So it was truly a screening algorithm. And again, this was based on the fact that there was such a high burden of injury among those patients who were sicker. Recommending obtaining an EKG, an echo, as well as a high sensitivity cardiac troponin if available, or any cardiac troponin assay. And any additional testing based on how, if of course, obviously if baseline testing was abnormal, but also based on symptomatology or persistence of symptoms upon return to play. Now, moving forward into the summer of 2020, we recognized that the national lockdown lifted. Now, clearly, there was some politicization. There still remains politicization throughout all this, as we are all aware. But the bottom line is this happened, and that meant that athletes were now beginning to return to competitive training. And several events occurred throughout the summer that, unfortunately, I think dictated a very unfortunate narrative about how to approach the athlete after COVID-19 infection. There are several anecdotal case reports. These are professional athletes, high-profile athletes that self-disclosed on their own that they had myocarditis after COVID-19. So not violating HIPAA, as this was all out there based on the athlete's disclosure, but Eduardo Rodriguez for the Boston Red Sox noted this. There were several other collegiate athletes that put out there on social media that they were suffering from myocarditis after COVID-19. But perhaps more of the issue was the fact that several observational case series came out throughout the summer of 2020 that really guided this narrative. And the first was actually not an athlete-based study, but this was a study from Germany. And I suspect everybody watching this remembers this study. I would submit that this was an observational case series, perhaps the highest impact observational case series in the history of medicine. This study has almost 1 million views, downloads. It's been cited over 500 times. It's not even been published for a year. And this was a simple study of 100 German patients who had COVID-19, and all of these individuals had a cardiac MRI. These individuals were young, but middle-aged, approaching middle age, about 50 years old. Importantly, 2/3 of these patients either had asymptomatic or mild COVID-19, and that's what really drove the concerning narrative from this study. And CMRs are obtained at a median time of around 71 days. This study was from, again, a group from Germany led by Valentina Putman. And what they showed was among the MRIs obtained, almost 80% had abnormal findings, 73% with a prolonged T1 time, 60% prolonged T2 time, about 20% had late gadolinium enhancement. What they showed was that in terms of the best discriminative ability to identify underlying cardiac injury was a prolonged T1 or prolonged T2 time. Now, this study had some issues for sure, and we could spend a half hour just going through this and also going through some subsequent follow-up study. There was a really important study looking at healthcare workers, healthy healthcare workers, which did not go in line with the findings from this particular study. But if we just focus on comparing these patients to athletes, clearly this was not an apples to apples comparison. Older patients, a not insignificant percentage of these individuals did have underlying comorbidities such as hypertension, and almost 40% still disclosed symptoms at the time of their cardiac MRI, which was over 2 months after the time they tested positive for COVID-19. So clearly, again, this wasn't your healthy athlete recovered, completely asymptomatic, and then ready to return to play. Now, moving forward, however, there were several observational case series coming from the athlete population that drove a concerning narrative about underlying subclinical cardiac injury. The first, which is really the poster child study for all of these, came from the Ohio State University. This was a group led by Kurt Daniels. And these were 26 Ohio State student athletes, all of whom had COVID-19, all of whom had asymptomatic or mild COVID-19 symptoms. You'll see this repetitive narrative throughout the studies I'm about to review, all of whom had this normal standard triad testing that were recommended from our initial ACC sponsored document. But throughout the Big Ten, they took the next step and mandated cardiac MRIs on every single one of these student athletes. And this is ultimately compiled in a large registry, which I'll discuss later in this talk. But among these first 26 student athletes, 4 of them, 15%, had CMR criteria as defined by the Lake Louise criteria for acute myocarditis. Now, of those 4 individuals, only 2 were symptomatic. And again, remember that the other 2 only had mild symptoms. And almost half had non-specific late gadolinium enhancement. We're going to get back to that here in a little bit. So of course, this drove a very strong narrative. I remember pieces out in the media discussing that athletes all had this myocarditis and, oh my gosh, what are we going to do? And certainly this was a very stressful time throughout my community, the sports medicine, sports cardiology community. I think it's first important, however, let's do a quick review of the Lake Louise criteria so we're all on the same page. Now, clearly one of our CMR experts could do a much better job of reviewing the LLC, but I'll just give a cursory background. So the first Lake Louise criteria were published in 2009, and they were predicated on the presence of 3 critical findings: the presence of hyperemia as identified by intense signal on early gadolinium enhancement imaging, edema as noted by increased T2, and the presence of late gadolinium enhancement reflective of underlying necrosis and fibrosis. Now, the sensitivity and specificity of these criteria weren't that robust, but it's important to note that these criteria were defined upon a patient population where the pretest probability of acute myocarditis was on the higher side. Now, these were updated in 2018 with much improved sensitivity and specificity through the addition of novel T1 and T2 parametric mapping techniques for improved accuracy. T2 mapping for edema, as well as T1 mapping and extracellular volume for inflammatory injury. And again, in the patient population where pretest probability was much higher, you see the much improved sensitivity and specificity. So clearly it's important to acknowledge that with all of these early observational case series, the Lake Louise criteria were utilized, but really in this patient population, the wrong patient population, where your pretest probability was not high. Obviously, these are all individuals that were infected, but none of whom reporting symptoms consistent with myocarditis, those being cardiopulmonary symptoms. And I think, again, the heterogeneity of these findings also discloses some clear limitations. And this is a perfect example. So this was a follow-up study, this in conjunction with a Rajpal study, where the first two studies which generated a lot of media attention. This was a study from student athletes at West Virginia University, a little bit larger population, but again, small, 48 student athletes, similarly asymptomatic or mild symptomatic COVID-19, and more than half had abnormal cardiac MRIs reported. However, in contrast with the Rajpal study, none of these individuals had CMR criteria consistent with the Lake Louise criteria for myocardial inflammation. They reported actually a large percentage, 40%, with pericardial enhancement suggestive of underlying pericarditis. They actually included some additional testing. They performed some fancy hierarchical clustering analysis, looking at associations between abnormal global longitudinal strain with abnormal pericardial enhancement. But they conclude that this was a common finding, the presence of pericarditis after COVID-19 infection, even in the population with, again, the lack of symptoms typically consistent with pericarditis. Now, here's the catch. We know that to date, there have been well over 5,000 athletes that have been published in various registry data, which we're going to review in this talk. And almost half of those, or maybe a little bit less than half, had cardiac MRIs obtained. The majority of those mandated screening CMRs. And in no study has there been anywhere the degree of abnormal pericardial enhancement as reported by this study. So again, that heterogeneity clearly suggests there may be interpretation bias, particularly when there was not a blinded review, a core lab review of these CMR. So a third study was published, and that was actually from Vanderbilt University. Again, this was one of the early observational case series from Clark and colleagues. And one addition to this analysis, which was important, and I'm glad they did this, was the inclusion of at least some controls. In the two prior studies I reviewed, there were no control populations included. And in this particular analysis, they included 60 healthy athletes, 27 non-athlete controls. The student athletes with COVID-19, similar to prior studies, again, no worse than mild symptomatology. And they reported 2 athletes, 3%, with myocarditis. And again, all of these athletes had normal standard triad tests. Now, we can stop here and again review some of the critical limitations, some of which I've already touched upon. So of course, the Clark analysis included some controls, but in no study were there any appropriate case control populations included. So a critical question, of course, is what is the clinical significance of these abnormal CMRs? What does a CMR look like 10 days after the flu or a common enteroviral infection? We don't know. Nobody's ever performed that analysis, certainly if you've had a severe URI. So a very important unanswered question. And of course, we're now using CMRs, perhaps the most sensitive diagnostic modality we have from an imaging standpoint, for screening purposes. And we don't have the appropriate normative CMR data to compare to. We haven't defined this for young athletes. So when you look at an abnormal T1 or T2 time that's just above an upper limit of normal, perhaps for that patient population at that institution, you don't really have that comparison healthy athletic population to compare to. So is it really abnormal is the bottom line question. Many of these studies were published in research letters, thus the study methodology for the CMR protocols employed were not well described. And I would actually put this last point at the top of the list now, which is, again, the fact that there was a lack of an independent core lab blinded review of these CMR studies. And that will be heavily emphasized throughout the remainder of the data we'll review. Again, there were other studies reported that push back on the narrative that CMRs are useful and that there's a high burden of underlying myocarditis that is present in this population. So this was a study from Wisconsin. At the time of this study's publication, this was the largest case series reported. about 150, 145 US collegiate student athletes from Wisconsin, again, were followed up. All of these individuals primarily had mild symptoms. There were a couple that had reported moderate symptoms. And only 2 of these student athletes were found to have evidence of myocarditis based on the Lake Louise criteria. Now, in this analysis, again, there was a large percentage of non-specific LGE, mostly at RV insertion points into the interventricular septum. So some may be aware of this, of the data looking at masters endurance athletes. This is actually not an uncommon finding, the presence of non-specific LGE at RV insertion points in the interventricular septum. Now, within an older endurance athlete population, it's felt that at least to date, at present, this is not pathologic. This may be more a physiologic phenomenon for those engaged in ultra endurance athletic training. But this really has not been reported in a younger competitive athlete population. So we don't want to jump to the conclusion that this non-specific LGE is a normal, healthy athletic finding. Of course, again, this is in the setting of an analysis and assessment after COVID-19 infection. So how much of this is related to viral infection, we don't know, but it didn't fall into the realm of a positive Lake Louise criteria, and certainly not consistent with acute myocarditis. So the authors conclude again that the prevalence of true underlying myocarditis is low, and that the utility of cardiac MRI is just not there, and push back on that narrative compared to the Rajpal study. So I had the privilege of writing the accompanying editorial to this piece in JAMA Cardiology, and one of the points that I emphasized was going back to the Bayesian philosophy of pretest probability. Again, when your clinical pretest probability is so low and the lack of having symptoms consistent with myocarditis, and you're using a highly sensitive diagnostic modality, you just don't know what the clinical significance is. And it's more likely that your specificity is just too poor, and you're picking up really more nonspecific false positive findings. So throughout the summer, there were other studies that I didn't go through, but really all consistent with the narrative, with the Clark study, the Rajpal study, some with the Sterkova study, with this heterogeneity of findings. And that just created a lot of confusion in the sports medicine community, because clearly, as we now headed into August, September, we now had college student athletes back, returning to play. College football was beginning, and there was just that question of how are we supposed to screen these student athletes, and are we letting a lot of student athletes return to play with underlying myocarditis? And this is a danger, which then leads into the broader question, should sports even be happening because of potential underlying health concerns after viral infection? So we all recognize there was a strong need for evidence. Ultimately, we needed outcomes data to really answer the question. We were never going to have years worth of outcomes data. We just needed data on what we were seeing with athletes returning to play, and ultimately how these athletes did upon that initial return to play. But that was going to take time. That wasn't going to happen overnight. But what we did have was the experience of sports cardiologists around the country, and those of us on the Sports and Exercise Cardiology Council who oversee very large centers. We were seeing a tremendous number of athletes at the universities we take care of, athletes referred into our clinics, the other teams we take care of. We were undergoing the standard triad testing. And our clinical observations were, we just weren't seeing a high prevalence of myocarditis, and we were allowing athletes to return to play. None of us were utilizing cardiac MRI because we at least saw the faults within these prior observational case series, and these athletes were doing just fine in terms of the return to play. So we felt it was important to update our initial recommendations. Again, these were clearly consensus-based, and at that time, the evidence that were reported were on the weaker side. We also felt it was important to address other populations of athletes at this time, younger high school athletes, masters athletes, and then an update on competitive athletes. And the group of us, again, we won't go through each and every one of these boxes. I'll just summarize these initial recommendations. In the absence of evidence, just based on our experience, felt that, again, those who are asymptomatic, there was no need for cardiac risk stratification. But given the fact that the majority of athletes we were seeing really had mild symptoms, mild URI symptoms primarily, loss of taste, smell, GI symptoms that were mild, the lack of cardiopulmonary symptoms that were being disclosed, And the standard battery of triad tests were normal. So cardiovascular risk stratification being unnecessary to proceed. And I would state that while there are some caveats to some of these initial recommendations, some of these recommendations that we put forth in October of last year, the general approach has actually not changed in the sense that the lack of cardiopulmonary symptoms not necessitating the need for cardiovascular risk stratification. Also stated that still should respect that self-isolation period, but exercise abstinence should be respected, recognizing that usually it's within that second week of illness where there may be clinical deterioration, and that's where that minimum 10 days came from. That's actually, I think, a piece that I would pull back on a bit now, and we'll get to that later in the talk. For those with moderate symptoms, systemic symptoms, fever for more than 2 days, systemic myalgias, chills, these were the athletes that we were recommending cardiovascular risk stratification, and of course, the presence of cardiopulmonary symptoms. So proceeding with the ECG, the biomarker assay, and the echocardiogram. And a strong pushback for the recommendation for a screening CMR. CMR reasonable to proceed if your baseline tests were abnormal. Obviously, if symptoms dictated the need, new symptoms with return to exercise, persistent symptoms, but not as a first-line screening modality. So these recommendations, again, were under support through the ACC, our Sports and Exercise Cardiology Council and section, and again, were put forth in October of 2020. So again, you can see this dynamic nature. These were only really 5 months after the first set, but again, felt it was important really to help guide those practitioners, those programs who didn't have access to a lot of the resources that, say, the Falcons have or any NFL team, where getting echoes and testing were easy to obtain, and certainly from a financial standpoint for those organizations, not a challenge. But for those patients, clearly without those resources, and clearly based on our clinical experiences, we felt it was important to put forth these consensus recommendations. Now, thankfully, as we move forward into 2021, finally, we had the benefit of some of these outcomes data. The first were outcomes data taken from professional athletes after COVID-19 infection, screening, and return to play. So all of these athletes underwent standard triad testing in absence of mandated screening CMR. CMR was only obtained if clinically indicated. And we were able to see actually the prevalence of underlying inflammatory heart disease. So this was a true team effort. Leagues such as the NFL, the NBA, Major League Baseball, MLS, and the NHL all work together to combine these data. And really, this is a truly remarkable effort. I'm not sure how many of you listening have experience with studying athletes, but as you can probably imagine, it's not that easy. And if you want to publish data just from one league, and you're dealing with unions and players associations, et cetera, it's virtually impossible. And I think you've seen that as it relates to some of the stories that relates to research and findings in other professional leagues. So the fact that this was a combined effort among every single professional organization in the United States, you may never see this again. This study was led by Matt Martinez. I was a co-author on this analysis given my relationship with various leagues, and many of the CMOs were also on the author byline. And what we found was consistent with what we were observing in our own clinical experiences. So 789 professional athletes had COVID-19 and underwent this battery of standard triad testing. And ultimately, only 5 athletes were diagnosed with inflammatory heart conditions. That's a prevalence of 0.6%. And the majority of these individuals all had asymptomatic cases or mild cases. There were no hospitalizations, to my recollection, related to COVID-19 among this cohort. This was followed up by the ORCA registry data. So Outcomes Registry of Cardiac Conditions in Athletes. This was a combined effort among 42 universities. So this was not an NCAA sponsored study, even though these were obviously all schools within the NCAA. The PIs were at University of Washington, John Dresner and Kim Harmon, and Mass General Hospital, Aaron Bagish. I was a member of the steering committee, still remain a member of the steering committee, and Emory and Georgia Tech actually contributed to that. So are two of the universities a part of this registry? And so the first question asked, as this is a registry that ultimately opts to answer many questions as it relates to competitive athletes and sudden cardiac arrest, sudden cardiac death, et cetera. The first question we asked obviously addressed COVID-19 and outcomes. So these were 3,000 student athletes, all of whom had COVID and returned to play. Within these 3,000 student athletes, 200 underwent screening CMR as well. It's important to note that these 200 were not a part of the Big Ten registry, which I'm going to discuss. So these were separate from the population of student athletes I'm going to discuss as it relates to the Big Ten registry. So within the 3,000 student athletes, only 21 were found to have cardiac involvement. That's 0.7% prevalence, which is remarkably in symmetry with the professional athlete registry. Looking specifically at the individuals who underwent screening CMR, you see the prevalence was higher, perhaps as you would expect, but it's important to note that the diagnostic yield was much higher if the CMR was a clinically indicated study. And what else is noteworthy? So if we combine the professional athlete registry, the ORCA registry data set, and even the Big Ten registry data set, which I'm going to discuss momentarily, is that over a year and a half later, to date, no adverse events have been reported, specifically as it relates to COVID-19 cardiovascular adverse events. So that's an important, clear point of evidence, specifically when you consider that the majority of these individuals, the overwhelming majority of the professional athlete registry and the ORCA registry did not have a screening CMR obtained. So we have to get into the Big Ten registry. I've certainly referred to it numerous times already. So again, this was the effort across the Big Ten, looking at outcomes post-COVID-19 and their student athletes with the addition of a screening CMR in combination with the standard triad testing battery of echo, ECG, and troponin. What they found in the 1,597 student athletes that underwent screening CMR was a prevalence of what they called COVID-19 myocarditis of 2.3%. But if we break down those 37 student athletes in more detail, we see that only 9 of those had clinical myocarditis. That's a prevalence of 0.5%, again, in remarkable symmetry to what was reported in ORCA and in the professional athlete registry data set. And 28 had what they had reported subclinical myocarditis. So this was myocarditis as solely defined by the Lake Louise criteria. So despite the fact that this study was clearly strengthened by number, sheer number, almost 1,600 athletes, I would submit that the same limitations that I discussed previously were unfortunately limiting to this specific analysis. And most importantly was the heterogeneity of findings. And that's detailed here in figure 4. So here we're looking at data from the universities 1 through 13 across the Big Ten. And we're looking at cases of myocarditis with the breakdown of CMRs performed. So if we specifically just focus on University 3 and 10. So in University 3, 14 cases of myocarditis, 283 CMRs performed. University 10 performed the most number of CMRs throughout the registry in only 1 case. And if you look across the Big Ten, the heterogeneity was anywhere from 0% up to 7.6%. If you look at the observational case series previously published, you'll find a prevalence of myocarditis anywhere from 0 to 15%. So that profound heterogeneity, again, I think, emphasizes the concern of potential institutional interpreter bias in terms of the review of these CMRs. There was no core lab blinded CMR review. And again, I think that clearly limits the extrapolation of or the interpretation of these data, for which the authors concluded that screening CMR was a better way of identifying underlying subclinical cardiac injury in athletes recovered from COVID-19. So of course, the question is there a comparable narrative? And the answer is yes. So I think you are aware of the controversy of screening ECGs in athletes and during the pre-participation evaluation, trying to identify underlying occult inherited cardiovascular disease that puts the athlete at potential risk for sudden cardiac arrest. So this is a figure I borrowed from Kim Harmon at University of Washington, and it's really just a cool slide emphasizing the improvement and the evolution of how we interpret the athletic ECG. And if you go back to 2005, the initial ESC athletic ECG interpretation criteria, you see a completely unacceptable false positive rate of 15 to 20%. And we see the tremendous improvement over the last 15, 20 years to 1 to 2%, which is still too high in my opinion, but clearly much better. And of course, now we're looking at the most sensitive diagnostic modality where we've not defined at all what the normative ranges are for healthy athletes, and we're utilizing that for screening. So clearly the concern for poor specificity, high false positive rates concern. And I'll take a quote from Kim actually, which really highlights this. We argue over a simple piece of paper, a very cheap piece of data, the ECG, and its value in terms of screening athletes. And there's this narrative among a select group that are arguing for using screening CMR now, which again, I think based on the data is highly questionable. So here I'm showing the sports eligibility criteria, the return to play for athletes with myocarditis. This is the 2015 sports eligibility document sponsored by ACC and AHA, that's on the left. And on the right is the updated Lake Louise criteria document. And I'll just emphasize that in both, there's the clear emphasis of pretest probability, the presence of a clinical syndrome consistent with myopericarditis, which then not only dictates for sports eligibility, whether or not one should be excluded from play if they've been diagnosed with myocarditis, but then now if we're looking at the LLC criteria, clearly emphasizing that those criteria were defined in a population where pretest probability was high. And if we look at the 2016 document from AHA just defining myocarditis, again, just jumping to the bottom, asterisk, if the patient is asymptomatic, you must have greater than or equal to 2 diagnostic criteria before a diagnosis of myocarditis could be met. And so if we highlight within diagnostic criteria 0.4, tissue characterization, clearly the presence of just the Lake Louise criteria in the absence of any other abnormalities actually is not consistent with a diagnosis of acute myocarditis. So how would I guide a current approach for a cardiologist taking care of somebody in the general population who's not an athlete? And then of course, we'll talk about where we're at for the competitive athlete or the highly active patient. Well, in general, and this is a critical point, for most patients, a return to exercise really comes without any special consideration. For most patients who are just trying to get back to regular exercise, even if there were symptoms, perhaps chest tightness, some shortness of breath, that there's complete recovery, there should be a gradual return to exercise. I don't think these patients should see their physician and ask or have to obtain special testing prior to return to exercise. These recommendations are really intended for the athlete, the exercise enthusiast, the highly active patient. And I would just encourage, and again, remembering that involving your sports cardiologist, obviously we have that here, but just in general, your colleague who has expertise in managing these patients is really appropriate for some of the more challenging cases. So we obviously recognize this field as a subspecialty similar to cardio-onc or cardiac OB-GYN. We published this through numerous review articles, state-of-the-art reviews through JACC. This was actually our most recent hot off the press from a couple weeks ago, where in this particular piece, we highlight the importance of shared decision-making. And again, when you're dealing with highly active patients who are requiring return to play prior to, or requiring evaluation prior to return to play, or if they have some non-specific abnormalities, given many of these individuals are still screened and testing is obtained prior to the return to play, remember that involving sports cardiology is a real important piece of the clinical evaluation and the approach. So for the competitive athlete or the highly active individual, again, similar to what we stated in October, and I would say present today, in the absence of cardiopulmonary symptoms, you don't need any sort of cardiovascular risk stratification. It should really be a gradual return to play. It's only if the presence of symptoms consistent with myocarditis are present, or if persistent symptoms are noted, for which a clinical evaluation is necessary. Now, again, we had previously stated that one should have exercise abstinence within those first 10 days, and that's probably not necessarily the case. And I think that's based on what we're seeing in our registry data, the very low prevalence of true clinical cardiac injury myocarditis. For those who are asymptomatic or when mild symptoms resolve, one can probably begin to resume competitive exercise training. Now, that can be a challenge, obviously, if you're self-isolating. Perhaps for the professional athlete who has a gym in their backyard, that's not so much of a challenge, but it certainly can be a challenge for a highly active recreational athlete. But it's just important to note that you probably don't have to abstain from exercise if you don't want to upon clinical recovery in those cases. And still, more extensive testing reasonable to consider, again, only if baseline tests are abnormal or if symptoms are persistent or recurrent with that return to exercise, but not as a first-line screening modality. And I don't think that these recommendations apply to different specific athletic populations. Again, extrapolating what we've seen among competitive athletes, certainly for the younger high school athlete, you think about MISC, masters athletes may have underlying cardiovascular risk factors, but in general, that initial approach being very much just based on concerning symptoms should guide whether or not these athletes should be tested. So of course, this is a famous quote from Carr, and I think it's an important quote, and it can be actually incorporated here. COVID being novel, of course, and there was much we didn't know in the beginning, but I think now based on the evidence, the approach should really be the way it's always been, which is that upon recovery from a viral infection, the presence of cardiopulmonary symptoms really should guide the clinical evaluation. And really there shouldn't be a quote unquote screening approach so much as a clinical evaluation in the appropriate cases. Now, there clearly many uncertainties remain. The approach to non-specific findings, the athlete that's referred with non-specific LGE, such as at the RV insertion point, or with an isolated elevated troponin. These are many referrals we've seen over the last year. Certainly we have guidance in these cases, but the significance for these still remains unknown, and we should call it an uncertainty. How to approach COVID-19 that's remote. Unfortunately, we're at the stage now where we've been at this long enough to where this is not uncommon. Doc, I had COVID 6 months ago, I had chest tightness, but you know what? I went back to my marathon training and I've been fine for the last 3 months. So dealing with where that line in the sand exists is something that we're working through and providing recommendations that will be out there shortly. Gray zone. So we recognize the gray zone typically with hypertrophic cardiomyopathy where there's a wall thickness that could be extreme athletic remodeling versus mild HCM. Well, you have an endurance athlete who had COVID-19, they had symptoms, you obtained testing, their EF is 50%. Well, is that again consistent with the athletic heart for the endurance athlete? Is it reflective of COVID-19 injury? These are some new gray zone cases that we're seeing in our practice. And the timing of return to play. So one of the positive findings in the Big Ten registry was the fact that in a subset, they obtained serial CMRs. And what they found actually was after a month, many of the abnormal findings had actually resolved. So that opens the line of how long after myocarditis should you wait before you resume competitive training? The guidelines state 3 to 6 months, but that's a 100% consensus opinion. It really lacks any evidence. And also, of course, if this is simply related to COVID-19, we don't know versus other viral infections. So the question of return to play, just in general after myocarditis, I think is a new, interesting research question that we should address and refine those recommendations. And of course, uncertainties as it relates to the long hauler. And so that leads into future challenges. We don't want to have the hubris to believe that things can't change. Of course, new variants. I'll say that with the Delta variant, I have not seen any differences in terms of more cardiac injury myocarditis in athletes who are having COVID-19 now compared to the beginning. It's really been the same, but that doesn't mean that could change, of course. And so we have to appreciate and respect the fact that recommendations can change based on how the virus changes. And these findings that have been reported by CMR in the Big Ten registry, of course, we want to respect, and determining the long-term clinical significance remains a challenge and an important question to answer. Challenges as it relates to PASC. So underlying mechanisms, obviously management remain very much uncertain, as you heard last week already. And I think this is the most important point. We have to be careful with cases of sudden cardiac arrest that are going to happen still in athletes in the relationship to COVID-19. Of course, we know that cases of sudden cardiac arrest happen before COVID. They're going to happen after COVID. And there have been a couple of high-profile cases. Again, I'm not violating HIPAA. This is all out there. But if you go back to the case of Keontae Johnson at University of Florida and Christian Eriksen, the international soccer player who had cardiac arrest in June, both of those individuals had COVID that came out there. And on social media, there was a lot of jump to that. And thankfully, I didn't see anybody at this institution do that. But I can tell you there are some respected names in cardiology that were making connections with the University of Florida athlete with COVID. Importantly, they actually went through an independent clinical review of that case, which was reported in the news a month or two later that case had nothing to do with COVID. Didn't generate as much national media attention, but the point is you got to be careful what you put out there. Just as much as you certainly want to vet every one of these cases, because things could change and perhaps COVID will become a much more unfortunate role with these cases, despite what we're recommending right now as it relates to the evaluation. So in summary, the prevalence of cardiac injury inflammation in athletes post-COVID-19 infection, we now know is low. The pretest probability of myocarditis should dictate the need for more sensitive imaging techniques. Certainly, it's the way it's always been, and it's the way it really should have been throughout this whole process. It's time to change the narrative from screening to the clinical evaluation of the athlete after COVID-19, and really change it from screening to the clinical evaluation after COVID-19 and return to play. And just to whet everyone's appetite, there's more guidance coming from us at the ACC. So I kind of akin this to the Star Wars trilogy. We have the first two parts. Hopefully part 3 will be the last time we have to do this. And this is a part of a much larger effort from the ACC to provide some guidance throughout all aspects of COVID. And this is through an expert consensus decision pathway that we're actively working on. So stay tuned with that. Thank you very much for your attention, and I will stop for questions.
Thank you, Jonathan. That was absolutely outstanding. I was wondering how you're going to talk about this for 45 minutes, and you've done it. So that's great. While I'm waiting for people to type in their questions in the chat, I'll start off with one. So, you know, that paper that you showed with over 700 people who tested positive for COVID-19 and then had an MRI. What was the time frame? Because you mentioned, 0.5% or 0.05% ended up with some evidence of myocarditis. But what was the average time?
So in the professional athlete registry is the one that had 790. So there were no screening CMRs in that cohort. That was all standard triad. So in the Big Ten registry, which was mandated, the time was variable. It ranged anywhere from a couple weeks to over a month. It just depended on the utility of when, and that's certainly an issue because obviously a question is could there have been abnormal findings that were just that through tincture of time had been present and then were just not there by the time they obtained the screening CMR, or if they were non-specific, maybe they truly had abnormal T2 in conjunction with the LGE, which would have been a case of myocarditis. But I think that really emphasizes again the point that despite some of those temporal limitations, the bottom line is that every one of these individuals have returned to play, and at least a year into this, these individuals that are within the registries, there have been no adverse outcomes, cardiac outcomes.
There's a question from Dr. Taylor. Long COVID creates a challenge in many of our long COVID patients that participate in recreational physical activity. So it seems like your recommendations related to cardiopulmonary symptoms might lead us to perform cardiac evaluation in these patients. Is that really the right thing to do?
Well, I think it for those in the general population who are not competitive athletes, I think it kind of goes back to, I would separate this out into the high-end exerciser to the individual who is just exercising for health. And I would not, even for those individuals, if they had chest pain, as a part of their illness, they get better and they want to return to exercise, and they presented and said, hey, I read these things about getting echoes in athletes. Well, the answer is no, you don't need all that. You can resume exercise. Now, then it becomes, I think, the individualized clinical assessment of that patient. If they try to exercise and they're truly suffering from long haul, I mean, that's going to be up to the practitioner in terms of determining, hey, are these symptoms potentially related to myocarditis? Because an athlete can have myocarditis, so can anybody in the general population. And so that, I think, is just going to be up to the practitioner in terms of if they're convinced that this is long haul versus are they suspicious that it may be something else. And then it's the evaluation, as you would anybody who presents to your clinic who had a viral infection and has bad chest pain. You're probably going to do some sort of evaluation to ensure they don't have myocarditis.
Okay, there's a question from Neil. Are there insights from these data that can be translated to vaccine-related cases?
That's a good question. And that's actually something that I think we're addressing more in this updated consensus pathway that I mentioned at the very end. And I would submit that, I mean, there's really no data to answer Neil's question, but what we do know is that all of those vaccine-related cases presented, and the reason why they came to fruition is because they had symptoms. And so I have not personally, at least in the student athletes and the athletes that I've seen, have had cases of symptoms within a week after vaccination. I'm sure around the country there's some sports cardiologists that have, and I've not been aware of a large number of cases related to the vaccine, at least among athletes. But I think in terms of the evaluation, similar to a patient that has myocarditis symptoms and they're a young individual, probably male, and they're within a week after vaccination, you're going to do an assessment. I would use those same recommendations and guidance for an athlete who has cardiopulmonary symptoms within a week after vaccination to look for it.
Jonathan, I have a question that's not necessarily related to COVID-19, but I'm just curious, with these high sensitivity troponins, I've always wondered, I mean, we only check troponins if there are symptoms. So tell me, when you exercise rigorously, like some of these athletes are just exercising a lot, at the end of their workout, if we were to check troponins, would it be elevated?
I'm glad you brought that up. It's almost as if I promise I didn't tell you to ask me that question, because it's an important point that I didn't actually get into these recommendations. And the answer is yes. And so when you check a troponin assay in an athlete for these purposes, they have to be abstain from any intense physical activity for 24 to 48 hours. And we know that based on data looking at marathon runners. We published data a couple years ago showing troponin elevations after the Peachtree Road Race. So it can happen. And certainly you want to make that clear. I think it's going to get a little bit better now compared to where we were in the beginning, where everybody was getting tested. Clearly, I think people are recognizing that it's the presence of cardiopulmonary symptoms that should guide the approach to athletes now. But we were certainly having some challenging cases where athletes were doing stuff, and then after the fact, it turns out that, oh yeah, they did stuff yesterday, even though we told them not to. And I can at least have one example in our clinic where the troponin was a little elevated. This was before high sensitivity, actually, but it was elevated, and then it just required some follow-up testing, which was unfortunate because it was clear to me that it wasn't clinically relevant. And that's also an issue because we don't have normative values for high sensitivity troponin in athletes, period. And so even throughout all of this, I think that was a challenge in the beginning when we were using, we were screening athletes, and we all recognized that. It was just just based on all of what we were seeing with among hospitalized patients that really kind of guided a very high level of concern in the beginning.
Okay, great. And here's our last question. Have you registered sudden deaths related to myocarditis complications related to COVID-19?
Yeah, no, that was a point of emphasis. Is I'm not aware, certainly among the registry athletes, and I've not heard of any, period. And again, we have to remember that COVID is such a hot button issue that if there's an athlete that drops dead due to COVID, we're going to hear about it. It's just kind of the way our media is. And I mean, you saw it with these high profile cases where people were trying to make it COVID related. And in both cases, they were not. And so I'm not aware of any to date.
Okay, great. Thank you, Jonathan, for that excellent presentation. Thank you all of you for attending. Don't forget to get your CME credit. It's best to do it as soon as possible right after Grand Rounds. You can just click on that link that Zaina sends. And I will see you next week. Thank you, everyone.
The preceding program is copyrighted by Emory University.